Hello, my name is Pengetahuan. I work at the World Health Organization in the Department for the Control of Neglected Tropical Diseases. This course emphasizes a cross-sectoral and integrated approach to rabies and aims to help you understand the importance of One Health in tackling rabies. All the course materials can be downloaded directly through the open WHO portal. This course is made up of 7 modules, which you work through progressively or as standalone topics. If you complete all the modules and successfully complete the final quiz, you can download a record of achievement at the end. Each module also has an optional short quiz to prepare you for the final quiz. Let's now quickly go through the content of each module. Module 1 is an introduction to rabies and describes its history, burden, and biology. Module 2 explains 0 by 30, the global strategy to eliminate human deaths from dog-mediated rabies, which is grounded in a One Health approach. Module 3 provides practical information about rabies prevention in people, including dog bite management, while Module 4 explains why and how rabies can be prevented in dogs. Module 5 focuses on the importance of increasing awareness and empowerment in an at-risk community and how to do it. Module 6 covers rabies diagnosis and surveillance. And the final module, Module 7, illustrates the economic gains of a One Health approach using rabies as an example. Now, I will guide you through the first module of the course, titled Introduction to Rabies, History, Burden, and Biology. In this module, you will learn about rabies and its impact on communities, rabies transmission and clinical signs, how to prevent rabies, and how clinical human rabies can be managed but very rarely cured. Rabies is a lyssavirus, one of the oldest infectious diseases known to people. Its name comes from Rabies, the Sanskrit word for violence, and from Lyssa, the Greek goddess of fury. Even to this day, rabies has always been associated with the madness of dogs. Records from over 4,000 years ago, from the laws of the ancient city of Ashuna, now in Iraq, list measures to be taken against owners of dogs whose victims died after being bitten. The history of rabies dramatically changed in 1885 when the French chemist and microbiologist Louis Pasteur developed the first vaccine against this incurable disease. Rabies is a zoonotic disease, or a disease that spreads from animals to humans, caused by RNA virus that infects the central nervous system. It is usually transmitted through bites, and in some cases, licks and scratches from infected mammals. Rabies is almost always fatal once clinical signs appear, but it can be prevented through prompt wound washing and post-exposure prophylaxis. Post-exposure prophylaxis consists of a series of rabies vaccines and in some cases, rabies immunoglobulins. You can find more information on post-exposure prophylaxis in Module 3 on preventing rabies in people. Tens of thousands of people are estimated to die of rabies each year. Almost all cases are spread by rabid dogs, and almost half of the victims are children under the age of 15. It is not possible to test people for rabies before the onset of symptoms, but all cases are preventable if post-exposure prophylaxis is given promptly after exposure. The burden of rabies is greatest in Africa and Asia, and many countries in the world have already eliminated rabies in dogs. Rabies deaths are widely underreported. In Asia, deaths are estimated to be 20 times more, and in Africa, up to 160 times more than reported. This means that estimates of the exact burden of disease vary widely from 25,000 up to 159,000 deaths globally each year. Underreporting can occur because rabies is misdiagnosed as another condition with similar symptoms, such as viral encephalitis or cerebral malaria, without laboratory confirmation. Many deaths are also not reported because they occur at home when victims are too ill to travel and know that there is no treatment available even if they do seek care or it is too expensive. This is compounded by weak surveillance systems in many endemic countries, especially in poor and rural communities that are chronically underserved and experience the greatest burden of rabies. Almost half of all the rabies deaths occur in children under the age of 15. Children are at greater risk of developing rabies because they play with animals and may not report bites to their parents, so they may not receive prompt care. They are also smaller and are more likely to receive multiple and severe bites, especially in the face or head. This increases the risk of rabies developing fast. Remember, rabies is fatal and cannot be cured. I will explain the transmission pathway in greater detail shortly. Rabies is estimated to cost $8.6 billion globally each year, as well as an incalculable psychological trauma for individuals and their communities. Of the financial cost, around 40% is for medical care, including direct costs of care which are often borne out of pocket by patients and can be catastrophic. Lost income while seeking care or travel costs incurred to access care, and control measures such as dog vaccination and surveillance. 54% is incurred through productivity losses due to premature death, and 6% through loss of infected livestock. Rural and poor communities are disproportionately affected because of less access to care and rabies control programs. These communities have less buffer to pay for medical care, travel expenses, and so on. When an income earner dies of rabies, families can spiral deeper into poverty. In addition, animals such as livestock are also lost to rabies, which reduces income and sustenance of communities. Rabies also particularly impacts low-income families. In one study, over 70% of low-income bite victims relied on loans or selling property to pay for post-exposure prophylaxis, while most high-income victims used family savings. Similarly, over 60% of low-income bite victims delayed seeking post-exposure prophylaxis by 4 days or more, which may increase their chance of getting clinical rabies, while 100% of high-income bite victims sought prophylaxis within 3 days of being bitten. Now that we have covered rabies and its impact on communities, let's talk about its transmission and clinical signs in people and animals. Rabies virus is transmitted through infected saliva, most commonly through a bite and sometimes through a scratch or direct contact with the eyes, mouth, or an open wound. It spreads slowly from the entry point along peripheral nerves to the central nervous system, that is the spinal cord and the brain. When the virus reaches the brain, it causes clinical signs, replicates, and spreads to the salivary glands, where it is excreted in the saliva and can infect others. In rare instances, rabies transmission has been documented from transplants of infected organs, inhalation of aerosol virus in laboratories, and then the handling of raw meat from an infected animal, for example, through butchering of an infected dog. Rabies has never been documented to be transmitted through the consumption of raw milk, nor transmitted through rodent bites. Post-exposure prophylaxis is therefore not indicated for raw milk consumption, nor for rodent bites. In people, the incubation phase, that is the period from exposure to showing clinical signs, typically takes between 4 and 12 weeks. Some rare cases have been documented to develop in less than 1 week or more than 1 year. The incubation phase is driven by how long it takes for the virus to spread from the site of entry to the brain. Where there is less distance to travel, for example bites in small children or bites to the face and head, the incubation phase is shorter. Hence, prompt medical care is even more critical to prevent rabies. Upon medical consultation, post-exposure prophylaxis should be started as soon as possible. But unless clinical signs are already evident, it is never too late to successfully start it. Once clinical signs appear, rabies is almost always fatal. Clinical signs in people typically start with generic symptoms for up to 1 week, such as fever, malaise, fatigue, lack of appetite, tingling at the wound site, and the disease progresses to furious or paralytic rabies. Furious rabies involves altered behavior, hallucinations, incoordination, aerophobia, that is the fear of drafts or fresh air, hydrophobia, that is the fear of water, excessive salivation, and aggression. This can last for up to 5 days. Paralytic rabies involves growing paralysis and can last for up to 14 days. Both furious and paralytic rabies lead to acute encephalitis or inflammation of the brain, followed by coma and death. In dogs, clinical signs follow a similar pattern. Dogs are infected with rabies through exposure to infectious saliva through bites, scratches, or contact with the eyes, mouth, or open wounds. The incubation phase is typically 3 to 11 weeks, and occasionally longer, before developing into generic signs for up to 1 week, such as fever, vomiting, weakness, and lack of appetite. Now the dog may develop furious or paralytic rabies for around 1 week, before progressing to acute encephalitis, coma, and then death. Signs of furious rabies in dogs include altered behavior, aggression, incoordination, difficulty swallowing, dropping jaw, excessive salivation, and a change in the tone of a bark. Aerophobia and hydrophobia are not present in dog rabies. As in people, paralytic rabies involves growing paralysis. Rabies virus is present in the saliva after the incubation period, meaning rabid dogs can be infectious even when their clinical signs are still mild. In people, clinical rabies can be managed but very rarely cured. If a rabies case is confirmed or clinically suspected, the treating physician will usually consult with the patient's relatives and offer palliative care either at the hospital or at home to support peaceful and dignified passing. In some cases, for example, where highly specialized and intensive care is available, the family may choose to pursue aggressive management involving critical care and rabies-specific treatments. However, recovery is extremely rare. In either situation, antibiotics are not an effective treatment for rabies. For further expert guidance on human and animal rabies, you can refer to the WHO expert consultation on rabies, the WHO position paper on rabies vaccines, and the terrestrial animal health code of the World Organization for Animal Health. References and links to further information are also covered at the end of this module. In this module, you learned that effective vaccines have existed for rabies since 1885. Rabies is almost always fatal once clinical signs appear. Post-exposure prophylaxis involves wound washing and a series of vaccines. It should be started as soon as possible after an exposure, but it can be effective as long as it is completed before clinical signs appear. Tens of thousands of people die of rabies each year. Most cases are caused by dog bites, and almost half of the victims are children. Poor and rural communities in Asia and Africa are disproportionately affected, and rabies is transmitted through infected saliva. Here are the links to the documents and research papers on the topics covered by this module. This slide provides you with additional resources, including other open WHO courses that you may be interested in. In the next module of the course, we will focus on the 0 by 30 rabies elimination strategy. I thank you for your attention.